The key is for all of us is to recognize what that really is. And again, one of the things we all talk about, I think, very well, and maybe practice not so well, is what is a frail patient, okay? And we have lots of scoring systems, we have lots of things that you can go down, we have tests you can do, but we need to do a better job of trying to figure out how to make that clinically feasible versus just using clinicians as the guide. And so finding ways to do that is gonna be a really important step, and I'm hoping that we can develop better biomarkers of what that really looks like, whether it be sarcopenia from imaging, whether it be lab tests that we can get, and physicians can see this right away. These are things that can be the next step to helping deal with the frailty of patients, because really we need to adapt the therapy to the patient. Like, there's frail, what we talked about, like, single drug, maybe adding things if necessary, but most patients can handle multiple agents. But again, they don't need to handle them at the full dose. These are all things that we really need to recognize and make sure are translated to the community where people are getting most of the therapy. Is that just because we say, triplet therapy, DRD for most patients that are transplant ineligible, quote unquote, or now even quads for folks that are more fit on that level, is that doesn't mean they need the full dose of any of these agents. They need to make sure that it's kind of truly adjusted for the patient in front of them, and make sure they get on therapy is the most important thing. So tools to help us do that a little better, I think, is gonna be a really critical next step for what we're going with treating our frail patients, because they do need these therapies, they do need therapy, but they need therapy to be given in a very respectful and responsible way.